Today I am going to talk about impingement sign happening in the shoulder joint. When the patients are abducting their shoulder or elevating their shoulder over it, one of the structures in the subacromial space will be compressing one of the tendons of the rotator cuff. Usually it is the supraspinatus muscle which will get compressed, and that causes pain during abduction, and once the range is probably completed, the pain will be significantly less, and as they come down again the pain will be more. Once they reach the neutral, the pain will disappear. It's a dynamic phenomena. That means only during the movement impingement will be exhibited, and once the patient is at rest or during static positions, the pain shouldn't be there. In other words, if the patient is having pain even during rest, it does not qualify to be called as impingement syndrome. Impingement is always a dynamic phenomena, and impingement is also a clinical phenomena, means clinically the patient should be exhibiting it. Just because in the MRI there is a subacromial spur, that doesn't mean that the patient should be having impingement. There are lot many patients whom we saw, there are so many spurs and calcifications in the tendon, and patients do not have the impingement sign positive. If they do not have the pain during abduction, that means the impingement sign is negative. No matter whatever the MRI says, that clinically if the impingement is not there, it is not there. Don't diagnose them as impingement syndrome just by looking at the static images in the MRI. But when the patient is having clinical sign of impingement or pain during abduction, and if the MRI says something like calcification or tendon rupture or tendon tear or AC joint arthritis, spurs in the subacromial space or acromial shape itself, sometimes type 3 acromia, type 2 acromia can cause the impingement. So these are the so many reasons for impingement. The impingement is a sign of something is compressing on something. So impingement is not a diagnosis. If you want to diagnose the reason for impingement, perhaps you may have to look into the MRI. This MRI is useful, but MRI alone is not 100% useful to decide on the treatment. Because there are some causes of secondary impingement where the position of the scapula may alter the dynamics of the movement of the shoulder, thereby it can cause secondary impingement, so for which we have to train some scapular muscles and then posture correction exercise and then shoulder bracing exercise where the scapular position will get restored back to normal. That reduces the impingement. Some impingements are purely inflammatory, for example acute supraspinatus tendinitis or partial thickness tear, that can cause impingement. As the inflammation reduces, the impingement can also reduce. So some impingements are inflammatory in nature, some impingements are mechanical in nature, some impingements are structural in nature, some impingements are secondary in nature where the scapular portion itself has to be corrected. So these are all the various types of impingement, but in the nutshell, impingement is a clinical sign. Impingement cannot be diagnosed only by MRI. MRI is useful to know what could be the potential reason for causing the impingement, but MRI alone is not always needed to do the right treatment. So we blend our clinical examination with the MRI findings, and then we choose which is the right exercise for the patient to reduce the impingement. Sometimes some impingements are purely anatomical, that they anyway have to undergo some subacromial decompression or something because of too much of structural fault. As a physio, you need to do a deeper analysis of this kind of things so that you can give a right solution to your patients.